Greetings from Danagare. My talk will be based on the following headings: introduction, goals of treatment, tackling each culprit, and take-home message. Introduction and goals. This has already been covered in brief by the previous speakers. As we know, the normal serum levels of two elements like calcium, phosphorus are maintained by three hormones: PTH, calcitrol, FGF23, and these four hormones act on the four target organs. 2, 3, 4 is a simple analogy how we can remember. So as we know, abnormalities begin early in the course of CKD and universally observed at a EGFR less than 30 ml per minute. And if you see this graph, most of the changes begin at this juncture at stage 3 CKD onwards, and as the disease advances, FGF23, PTH, phosphorus will increase, and calcium and calcium decreases. So goals of treatment basically to regulate serum PTH concentrations within an acceptable range and prevent the progression of parathyroid hyperplasia in order to maintain neutral phosphate and calcium balance, to prevent hyperphosphatemia, hypercalcemia, and thereby minimize vascular calcification, and also to improve the bone health by reducing the fracture risk, and also provide adequate vitamin D supplementation basically to optimize innate immune functions and other biological actions of the vitamin D, and also to reduce the morbidity and mortality associated with CKD MBD. What does KDIGO recommend? This was discussed previously by the speaker. So just to highlight the parameters measured like PTH, calcium, phosphorus, and PTH at stage 3 CKD need to be documented at baseline, and calcium phosphorus need to be measured annually or biannually. As the stage of the CKD advances, the frequency of monitoring also increases. And what are the target ranges recommended by KDIGO? The levels of calcium phosphorus in stage 3, stage 4 need to be maintained in a range of 2.4 to 4.6, and calcium 8.4 to 10.2, and PTH between these ranges. And in stage 5 there is some lenience to the phosphate level, that is up to 5.5, 3.5 to 5.5 it can be maintained, and PTH need to be maintained between 2 to 3 times the upper limit of normal. The other guidelines recommend in these following ranges. So before we understand how to manage hyperparathyroidism, let us discuss in brief what are the interlinked mechanisms which leads to hyperparathyroidism, so that it helps in taking decisions in the management of hyperparathyroidism. So with the progressive renal dysfunction, there will be decreased phosphate excretion, and there will be phosphate retention, which leads to secondary hyperparathyroidism. Increased phosphate levels combines with the circulating calcium levels, decreases calcium, leads to secondary hyperparathyroidism. With increased phosphate retention, there will be increased FGF23 and leads to phosphate excretion, and also this increased FGF23 it decreases the 1,2,1-alpha hydroxylase level, which in turn leads to decrease 1,2,5-dihydroxy vitamin D, and in turn it leads to secondary hyperparathyroidism. So the targets, basically we need to address the phosphate, we need to address the calcium, control of calcium, and we need to address by using calcium mimetics. So let us discuss one by one. Prevention of hypocalcemia. Why do we need to correct hypocalcemia? Because it's as we know, it's a potent stimulant of PTH secretion. In 2009 KDIGO guidelines, it suggested maintaining serum calcium levels in the normal range, but in 2017 guidelines, it suggests avoiding hypercalcemia, and it emphasizes maintaining treating calcium hypocalcemia by an individualized approach, and also it stresses on managing basically significant or symptomatic hypocalcemia rather than correcting asymptomatic or mild hypocalcemia. And in patients with CKD stage 5D on dialysis, it emphasizes to maintain calcium levels between 1.25 to maintains dialysate calcium between 1.25 to 1.5 millimoles per liter. So control of phosphate, it's a cornerstone in the effective management of CKD MBD, and newer KDIGO guidelines suggest maintaining elevated phosphorus to the normal range, and it emphasizes on phosphate lowering treatment instead of phosphate binding agents, because it stresses that the management used to all approaches used to control phosphorus are effective, like using drugs, dialysis, or diet. So two approaches, one is dietary phosphate restriction and phosphate binders. So this part I'll skip because of time constraints. So coming to phosphate binders, we know the dietary phosphate intake, if we calculate like 1000 milligram per day, it will be 7000 milligram per day. In that 4200 milligram per week will be observed. And if patient is on hemodialysis, like 800 milligram per session will be removed. It will be 2400 milligram per week removed. So still the positive balance will be 1800 milligram per week, and it need to be removed over a period of 7 days. So with the help of binders, at least 257 milligram per day need to be removed. So how do we classify phosphate binders? We classify based on these following headings: calcium containing, calcium carbonate acetate; non-calcium containing, sevelamer hydrochloride carbonate, lanthanum carbonate; ferrous, the newer phosphate binders, ferric citrate, sucroferric oxide; and older less used salts, aluminum hydroxide. Brief mechanism of action: calcium carbonate, lanthanum carbonate and calcium acetate, they form insoluble calcium phosphate by binding to dietary phosphate. And ferric citrate, ferric ions bind to dietary phosphate ions and forms ferric phosphate precipitate, which is excreted in stool. Sucroferric oxide occurs by exchange of ligands between the dietary phosphate and hydroxyl groups. This is a brief comprehensive guide of different phosphate binders. I will stress upon the newer phosphate binders. Basically, iron citrate, it comes as a 1000 milligram tablet, 2 tablets per meal, approximately 6 tablets per day can be used. If the goals are not attained, up to 12 tablets per day can be used, and the binding capacity of phosphorus is 19.8 milligram per gram of ferric citrate tablet. And sucroferric oxyhydroxide, it comes as a chewable tablet in the strength of 500 milligram. 3 tablets per day can be used and increased up to 3000 milligram per day, and the phosphate binding is 130 milligram per gram is the binding capacity. So even KDIGO suggests restricting the dose of calcium-based phosphate binders in CKD stage 3 and stage 5D. So various trials are there, just want to highlight few. In use of ferric citrate coordination complex compared to placebo and ferric citrate group. Ferric citrate group, there was a significant reduction in serum phosphorus level, and when the study was combined with the active control group, there was no much of significant reduction, but however, it was non-inferior when compared to the active control group. Use of sucroferric oxyhydroxide. This study was done over a period of 1 year in hemodialysis patients. And if you see here, at baseline, the pill burden was 8.5, and over a period of 1 year when it was followed, the pill burden was reduced to 4.4, and even patients achieving the target level of phosphorus, that is less than 5.5 milligrams, was increased from the baseline 14% to 23 to 34.1% over a period of 1 year. And another study combining sucroferric oxyhydroxide with sevelamer. In this study, if you see, the absolute mean serum phosphorus level decreased in both the treatment groups, but this was more pronounced in sucroferric oxide group at early time points. And also, if you see here, the target serum phosphorus was achieved earlier in sucroferric oxide group compared to sevelamer, and also the pill burden also was less in sucroferric oxide group compared to sevelamer group. Do we have any other newer strategies? These were the 2 drugs which were tried, tenopranor and sodium phosphate potassium inhibitors. Nicotinamide, basically it inhibits the expression of sodium potassium 2B inhibitors. Because of this decreased expression, it leads to decreased absorption of the phosphorus. And tenopranor, basically it inhibits sodium ion exchanger. Because of this inhibition, the protons get accumulated, which leads to conformational change in the paracellular pathways, which leads to decrease in absorption of the phosphorus. So this was a trial used to compare nicotinamide plus phosphate binder with placebo plus phosphate binder. In the group which was treated with nicotinamide plus phosphate binder, at 12 groups, there was significant reduction in the phosphorus levels, and also there was significant reduction in PTH levels. And also, if you see here, the phosphate reduction began at week 2 and it was persisting throughout 12 weeks, and even the pill burden also was less in patient treated with nicotinamide. So patients, this was one of the study to compare use of tenofovir. The patients who were treated in tenofovir group plus phosphate binders, there was significant reduction in phosphorus levels at 8 weeks compared to placebo plus phosphobinder group. So this was another study to study the effectiveness of tenofovir on with other phosphate binders. At week 22, if you see here, the baseline pill burden, which was 14.7, it was reduced to 3 at week 22, and the phosphorus concentration also was significantly reduced from at baseline it was 5.19, and at 24 weeks it was 4.71. Vitamin D analogs. We know that calcitriol is there, and what are the concerns we have when using vitamin D analogs? In mild to moderate CKD, it can increase the progression of disease. Calcitriol causes increased phosphate absorption, hyperphosphatemia, and increased product. Calcitriol doses up to 0.5 microgram are not associated with hypercalcemia. What is the concern to use of vitamin D metabolite can predispose to adynamic bone disease. Vitamin D metabolites usage before dialysis definitely can lead to oversuppression of the PTH and predispose to adynamic bone disease. And vitamin D therapy should not be started without the prior documentation of hyperparathyroidism. And we need to correct 25-hydroxy vitamin D before starting the vitamin D therapy. So when to start? In early stage of the CKD, what need to be kept in mind? Document hyperparathyroidism, correct deficiency of 25-hydroxy vitamin D, document hyperphosphatemia, side effects, hypercalcemia, discontinue if calcium levels are more than 10.2, discontinue if phosphorus levels more than 5.5. When to resume? Once the hypercalcemia, hyperphosphatemia is addressed, resume vitamin D at 1/2 of the dose. Calcium mimetics, as we know, it increases the sensitivity of CSR to calcium, reducing the plasma PTH concentration, thereby it decreases serum calcium phosphorus levels. We have three: sinacalcet, tetacalcetide, and evocalcet. Sinacalcet given as a oral, tetacalcet given as IV. This was the study at 12 months. There was significant reduction of PTH, calcium, phosphorus, and alkaline phosphate parameters, and this reduction was sustained and gradual. And between evocalcet and sinacalcet, it showed that evocalcet was non-inferior to sinacalcet, and the effective achievement rate was 72.7% in evocalcet group compared to in sinacalcet it was 76.7%. So one more etacalcetide in HD facilities which used etacalcetide as first regimen, there was significant reduction of PTH level compared to sinacalcet first in HD used. This was use of calcitriol plus sinacalcet. The group which used calcitriol plus low dose sinacalcet, there was significant reduction of calcium, phosphorus, and PTH levels. Last slide. In take-home message, to reduce the adverse effects of secondary hyperparathyroidism, dietary phosphate restriction plus phosphate binders play a key role. Newer phosphate binders with reduced pill burden helps in improving patient compliance. Combination of calcium mimetics with active vitamin D in selected cases helpful to keep PTH under control. Efficacy of other agents like sustained release nicotinamide, tenofovir, newer calcium mimetics need to be evaluated. Thank you. Sorry for the delay.